For the last talk of the day, I would like to invite Dr. Anand Parthasarthy, who will be telling us how to use all our might to manage keratoconus.
For the AIOS and the moderators of the session to allowing me to be a part of this. And I know all of you are reasonably tired, but I must congratulate the last people who are still standing strong. So when I got this topic with all our might, so I decided, let me see if I can give all my might, and I realized that I would need a substitute. So that's the only way I can actually get 8 packs. So no financial interest, but it would be nice to have some. So I guess interventions for irregular corneas or keratoconus is basically broadly into something on the cornea, something in the cornea, something beyond the cornea, smile as in additions. Now, when you look at ectasia treatments, you can look at index, you can look at topoguided PRKs, you combine it with phakic IOLs. There is a very, very good outcome with specialty contact lenses, or of course you can have combination of CXL. But what, as a patient, what are the bugbears for the keratoconus patients? It's about having poor uncorrected visual acuity, or at least having reasonable best corrected vision. They do complain of halos and ghosting, and there is always a small fear of losing vision. I'll start with one of my patients, a software engineer with Oracle. I work in Chennai, so not surprising. Diagnosed to have keratoconus about 15 years back. He's RGP intolerant. He's tried scleral lenses too, but was not comfortable. He's consulted all major eye hospitals in the country, and he presents with these kind of corneas which got very significant central scarring, and that does occur when you're wearing contact lenses 10-20 hours a day for almost about 10 plus years. So very, very significant central scarring. But he's also done intensive research on keratoconus in me. He's read all my papers published. He knows all the layers of the cornea compared to most postgraduates I know. He also has a discussion on my success rate of achieving the big bubble during surgery. And I did do my surgeries under local anesthesia at that time, and intraoperatively asked me if I'd actually achieved the big bubble or not. Luckily for him and me, the surgery went perfectly, and after about a year, he maintained 6x6 vision, all switches were out, and now he wanted an ICL with this refraction. We did an ICL, but he had also contacted a lot of surgeons because he wanted the one without the PI, which was actually that time not available. He's good, he's 6x6, he maintains vision. And this is about post almost 12 years post DALC ICL implantation, still maintaining good vision, all switches out, and sometimes combining the treatments does give good results. Now, when you're looking at keratoconus treatment, picture on the left and right both have similar management. Just for record, that is not me. You need to stop the progression, you need to stabilize the bulge, you need to improve the contour through intervention, and you need to have measurable results. And this is my paradigm management of how I do it. And broadly, I prefer to do it as structure and function, early and advanced keratoconus. So if you have an early to moderate keratoconus or post-LASIK ectasia, which technically is grade 1 to 3, and if it's progressive, you definitely need to treat it. If patient has reasonably regular astigmatism, has good vision, you can give contact lenses, provided you follow it up with a collagen cross-linking. Both scleral lenses and toric ICLs work very well. You can occasionally combine it with rings, which are the case or the PMMA rings, and you can do a topo PRK post that, combining it with the collagen cross-linking. If you have irregular astigmatism, like the topography on the right, you probably need to regularize it. So you can do rings, which tends to work well, and then combine it with the topo PRK collagen cross-linking. I feel that is a good option. If you have slightly more advanced keratoconus with no central scarring, you would probably do a collagen cross-linking, gives scleral lenses, works well. You can reduce the irregularity, reduce the cone by using rings, by combining with CXL or even a scleral lens. For slightly advanced cases, if there is stability, ICL works quite well. But if you have central scarring, like the patient I showed you earlier has poor vision, you're probably looking at a down. This is just a couple of pictures of the patient. The top is of the right eye, where we did collagen cross-linking, followed up with an ICL, and the bottom had slightly more advanced keratoconus. So we did intracorneal rings, and then for the residual astigmatism to reduce the sphere and the cylinder, we did the toric ICL. This is just a set of reports for the topo-guided PRK in our center for a 1-year follow-up when you're actually combining topo-guided PRK with the CXL. It gives fairly good stable results, but remember these are for milder cases. But there are some pointers when you're trying to combine collagen cross-linking either with intracorneal rings or toric ICL. Remember, you're trying to combine two different mechanisms of treatment. ICL is a refractive correction, it's a lot more predictable, but it's a one-time treatment. CXL is a biomechanical cellular process, so you have a future which is unpredictable. So in ICL cases, if you're putting ICL in a collagen cross-linking, always aim for at least about a diopter and a half of myopia. Now, Intacs is a mechanical, both the KS and the Intacs are mechanical effect on an ectatic cornea. So they have different mechanism of action. So you need to understand and then plan it. I prefer the stage procedure, usually about 2 months apart, at least for the CXL and the Intacs. Now, I believe it's a revolution in evolution. We started in '99 when I was doing a post-graduation to almost about now where we are actually combining a lot of treatments. Probably my impression is by 2030 we'll probably be treating it with eye drops and probably slit lamp based treatments. Just to go back to that previous patient, he actually got married in 2012. He and his wife sent me a questionnaire regarding the genetics of keratoconus, risk probability transmission of their disease to the offspring, which I frankly did not know. I did read up, but I'm told it's less than about 2%. He's still happily married and has a daughter now, about 12. So in conclusion, surgical options for keratoconus corneas using nomogram give good visual results. A combination of treatments, almost all have good successful surgical alternatives with an improvement in the uncorrected and the best corrected vision. And the long-term follow-up does indicate a continued effect. Thank you so much.
Thank you, sir. It was a very good presentation, very nice slides.
If you're within about 8.5, at least in Indian cornea, very unlikely you will have recurrence, but it's a thought.
Thank you so much, Dr. Anand.